Welcome back. In this part 3 lecture of screening for the lumbar spine in physical therapy, I'd like to talk through the remainder of our differential diagnoses for screening out serious spinal pathology. And we're going to pick back up with screening for spinal malignancy or cancer. So thinking through what some of the key signs and symptoms that we're going to be watching out for, and then what might be the medical management for this. You can jot some of those down before we move on. Okay, so as I mentioned prior, with spinal cancer, bone is a common site for metastasis, and in particular, spinal cancers, a common site for secondary cancers, not necessarily primary source of cancer. And within the spine, thoracic is more common than lumbar, and then lumbar more common than cervical. One of the acronyms that is oftentimes used, and this will give us a nice mnemonic or a way to remember the different types of primary site cancers that refer or metastasize to bone as a secondary site or spine as a secondary site, is P.T. Barnum loves kids. So the first letter of each of those words. So prostate, thyroid, breast, lung, and kidney are common primary cancers that will refer to bone. And with spinal metastasis, with these lesions in bone, oftentimes what's happening is that space-occupied lesion is compressing the spinal cord. So we may have what's called metastatic spinal cord compression, or MSCC, as a contributor to some of the symptoms or signs and symptoms that we're picking up in the patient exam. And vertebral fracture is also another sequelae or possible complication. An anterior wedge fracture is oftentimes common with spinal cancer. So we want to be screening, we want to be thinking about history of these different types of cancer, primary cancers, as we're screening the spine, and then what are some possible indications based on the pathology. So key signs and symptoms we want to be screening for. Highest evidence really supports the top two, which is history of cancer. As we said, common secondary site is in the spine, so history of another type of cancer could raise our suspicion of this as serious spinal pathology. Unexplained weight loss, as cancer is a highly metabolic tissue, it can cause increase in metabolism and unexplained weight loss. As age increases, we know that the incidence or the risk of cancer increases, so age is a risk factor, although by itself doesn't overall raise suspicion. As we saw in the case study, age, just because you're over the age of 50 doesn't mean you have spinal cancer. You could still have mechanical low back pain. Other factors that increase the risk or increase our suspicion could be night pain, constant pain, malaise, or some sort of systemic symptom besides just a musculoskeletal pain complaint, neurologic signs and symptoms, which might be more indicative of that metastatic spinal cord compression. And always keeping in mind with our suspicion of something that's non-musculoskeletal is not being able to reproduce signs and symptoms upon exam, or having kind of a funny pattern of symptoms, some like odd symptoms that don't really fit a clinical picture, a clinical pattern of what we might expect for a musculoskeletal pathology. For example, not really having clear aggravating or easing factors for symptoms or for an individual back pain will start to raise our suspicion. And this is particularly important as we think about cancer. Commonly described are some of these kind of odd or out of place symptoms. We'll go through that a little bit more in the next slide. Medical management, MRI is going to be the gold standard to screen for metastatic disease, and then cancer treatments could include surgery, chemotherapy, radiation treatment, depending on type of cancer, sites, if it is in the spine, how easily it is to operate on, things like that. So again, this is another really nice communications tool as we interact with our patients and as we try to really communicate with them. If we have a suspicion, we want to perform, again, watchful waiting as a physical therapist, but we want a safety net. So we want to educate our patients on what are some of these signs or symptoms to really look out for that they need to seek care for. So as you'll notice, some of these red flags in this card are funny feelings, odd sensations, things that we wouldn't necessarily expect from a musculoskeletal pain complaint. And so early warning signs of MSCC, again, that MSCC refers to metastatic spinal cord compression. So the spinal cord is the symptom generator as the cancer puts pressure on it. All right, moving on to our next diagnosis, which would be spinal infection, as we're screening for the serous pathology. What might be some key signs and symptoms, medical management. So risk factors for infection, as noted in our clinical decision model guidelines and the decision tool, we want to be aware of these risk factors in the context of other red flag symptoms, although as we see, one alone is not going to help us diagnose or necessarily raise our suspicion. A couple of these may raise our suspicion quite a bit. So as the percentage of prevalence of, so SEA is spinal epidural abscess or an infection in the spine. As we have an increasing number of risk factors or red flags, that's going to raise our suspicion higher versus just one alone is not going to be enough to maybe refer or suspect the serious spinal pathology. But IV drug use is kind of the top of the list, and you can kind of read through those other risk factors. But the key here is that we want to look for the presence of multiple things that's going to raise our suspicion. Kind of the classic triad of symptoms for spinal infection is the presence of back pain, fever, and neurologic symptoms. So if we think of fever as a symptom that is indicative of some sort of systemic issue going on, not going to expect that that is present with a musculoskeletal or a mechanical low back pain. Fever doesn't really fit the clinical picture. So if somebody has malaise, fever, indications of possible systemic infection, then we might be more suspicious of spinal infection. Another indication that would raise our suspicion, if an individual has had lab work done, high erythrosedimentation rate or ESR, as it indicates presence of some sort of inflammation or response to illness, injury, in this case infection, is something that can be more predictive of spinal infection. We went through some of these other risk factors in the prior slide. Medical management for a spinal infection, early treatment is best. We're going to diagnose with potentially a combination of MRI, blood work, potentially a chest x-ray, and treatment with the form of medication. One last thing to note is that this classic triad, it's rare for an individual to come in with all three of these things. So they may present with back pain and fever, or back pain and neurologic symptoms, or some of the other two. But if we're seeing this patient for spine pain, they're going to have back pain. Back pain and fever, those two that are asterisks, those are really the most common. So again, the importance of screening for some sort of systemic indicator within our patients who come in with a diagnosis or a referral for musculoskeletal pain. We really want to screen with that in mind. All right, moving on to the last diagnosis that we'll cover in this PowerPoint, and that is abdominal aortic aneurysm. So thinking through what are some key signs and symptoms you might think of for this, and then medical management. So an aneurysm is just a bulge in the wall of a blood vessel. So the blood vessel lining or the intimal lining has been compromised, and so there is a bulge, puts an individual at risk for a rupture, and that's really what we're most concerned about. So treating the bulge before it ruptures could be indicated, and we really do want to avoid that rupture. So in this particular diagnosis, the clinical triad that's been researched and talked about is the presence of abdominal or flank pain. So this could be a low back pain, a side pain, sometimes a groin pain is described. Pulsatile abdominal mass. So being able to palpate a pulsing mass in somebody's abdomen has higher specificity than sensitivity. So if it's present, spin versus snout. So if it's present, it helps us rule in more than if it's absent, it helps us rule out. So if you follow that but neither is perfect. And so again, we want to utilize multiple things. We don't just want to go off of the presence or absence of being able to palpate something pulsing in somebody's abdomen. Hypotension could be indicative, as we have blood vessel compromise, and particularly in the case of rupture, but I believe also in the case of an aneurysm, lowered blood pressure because of that vascular compromise could be present. And these individuals are not going to present with positional or movement-based aggravating and easing factors because it is a vascular issue. Those sorts of things aren't going to affect their symptoms. So a pattern that doesn't fit, or a nonsensical pattern to their presentation, doesn't fit with our mechanical idea of what back pain should report as we start testing it with our provocation tests, movement tests, things like that in our exam. We want to watch out for vascular risk factors, and in particular, this is more common in males with increasing age. Smoker, sorry, there's a typo on that. It shouldn't say smokier, it should say smoker. Family history of this and other vascular issues, so high cholesterol, things like that. If an individual is taking antihypertensives or statins, that could clue us into some of this underlying pathology, or if they're not, that might be something indicated to try to treat some of these risk factors, smoking cessation. If somebody does have this and it is of a great enough girth to indicate surgery, surgery would be appropriate to try to reduce incidence of rupture. They're going to go in and they're going to repair that site of the aneurysm. So that could be indicated, and there are a couple different surgical procedures that are present. Let's see. The last thing I wanted to bring up with this diagnosis is, and this is from low back pain clinical practice guidelines from Leda et al. In 2012. That was published in JOSPT, and this is another just kind of nice reinforcement to the idea that one single red flag or one single finding alone is not going to be enough to help us out with screening, because as you'll see, so abdominal girth, which we didn't mention, but that swelling, high sensitivity, but not very good specificity. And then palpation of that aortic pulse or the pulsatile mass, again, higher sensitivity, not as good specificity. So we're not necessarily able to rule in with a positive. We can more likely rule out if it's negative, but not completely. So thinking about these clusters of signs and symptoms and really performing our comprehensive exam to see if there are aggravating and easing factors, to see if it does behave like back pain that we're accustomed to seeing in the clinical setting that is mechanical, that we can treat with movement-based interventions primarily in physical therapy. So clinical takeaways for lumbar spine screening. When in doubt, refer out. If we have doubts that this is mechanical low back pain, musculoskeletal origin, depending on the severity of our doubts, as they increase, we really want to refer right away. If we pick up on anything where we suspect some sort of emergency scenario or pathology, we want to get that individual to the emergency room and get them the care that they need. Screening for these serious pathologies is always best practice. We should be performing these screens for each one of our patients who come in with low back pain. Imaging is often not indicated for nonspecific low back pain. In the absence of high suspicion of some serious pathology, most patients do not need imaging. And in fact, imaging can be harmful to patients by introducing some indication or some sense that something is wrong with them. We do know that there are high incidences of asymptomatic findings on the imaging. So unless findings from that imaging match up with a clinical presentation, it really doesn't help our clinical picture or our treatment guidelines. And in the day and age where we're trying to really promote value-based care, in other words, we're trying to be judicious with our use of these high-cost interventions, imaging costs a lot of money. And if patients don't need it, if it doesn't improve their care, we really don't want to overutilize imaging. If a patient doesn't improve within a reasonable amount of time with physical therapy, then it's worth getting a second opinion. It's worth seeking further testing. If an individual comes in with musculoskeletal based back pain, their prognosis is good. We think they should improve over the course of 4 to 6 weeks. Acute low back pain should get better, even if we utilize minimal interventions. So if it's not, then we want to seek out more information. The risk of these serious spinal pathologies that we're screening for increases as age increases. And it also increases as we find more risk factors or red flags from a patient history or patient exam. And so by doing our due diligence, we always want to perform a really thorough subjective and objective exam. So it's nothing new to you, but just to reinforce that point of being really comprehensive with all of our questioning and all of our testing. So here are references for the PowerPoint slides above, and hope you enjoyed the presentation on lumbar spine medical screening in physical therapy.